Hi, everyone. Brian Lewis here with Kidney Can. It's my pleasure to welcome you back to another edition of the National Kidney Foundation and Kidney Can's NKF Live series. Today, we're going to be discussing the topic of kidney disease and kidney cancer and the connection between them. We're going to try to connect the dots. And today, my guests include Dr. Sabine Karam. She's the Associate Professor of Medicine and Nephrology and Hypertension. She got her medical degree from, I'm going to butcher this, it's French, I believe, or in Beirut, Lebanon, from the Faculty de Medicine, University St. Joseph. And her internal medicine residency was at Albert Einstein College in New York, as well as at George Washington University. Number of other degrees from around the world, and we'll let Dr. Crom talk about that in just a moment. Really appreciate you being here, Dr. Crom. Thank you so much.
Thank you for having me.
We're also joined by Diane Beaumont, and Diane lives in Seattle with her husband, Michael. Michael, who has a long history with kidney cancer. He received his treatment and follow-up at the University of Washington and at the Fred Hutch Medical Cancer Center. And Diana's been a caregiver and an advocate and a medical manager for over 10 years. Diagnosed with his first kidney cancer in 2000 and then followed with a full nephrectomy and 5 years of scans. He appeared to be free of cancer until 2015 when the cancer returned to his other remaining kidney. And then 3 years of targeted therapy and immunotherapy were not enough to knock the disease back. And so he lost his remaining kidney in 2018. So dialysis became immediately necessary, first in a clinic and then at home. And so Diana's been a part of administering the treatments 4 days a week, and Michael became a good assistant. So after 3 years of being on dialysis and no appearance of any further kidney metastases, the dialysis nephrologist suggested that Michael might try to receive a kidney transplant to replace the need for dialysis. And that effort was successful. And so now Michael enjoys an active life. So we're really excited to hear from Diana and her perspective. So thank you both for joining me today.
Pleasure.
Great. So Dr. Crom, I'm going to start with you. I'm going to ask you for a medical explanation, what does kidney cancer or kidney disease do that puts you at risk for additional illnesses, including kidney cancer?
So kidney disease does put you at high risk of having cancers in general. And among them, kidney cancer is one of the most frequent. And the more advanced the kidney disease is, the more you're at risk. And actually, getting a kidney transplant doesn't remove the risk, because patients who get a kidney transplant are also at a high risk of getting cancer. And the relationship is thought to be to the fact that kidney disease is a disease where there is very high inflammation and, in general, a weak immune system if you are at an advanced stage. And we know now that those are things that put people at risk of having cancer.
Thank you for that explanation. Diana, I'm going to turn to you. First of all, please elaborate on that overview I just gave about your situation and your husband. And just talk to us a little bit about what first happened in 2000 and then bring up to today as quickly as you can.
Yes, Michael was first diagnosed in 2000. And at that point in time, surgery was about the only option. At least that's what we were told. So Michael lost his first kidney, the entire kidney, in 2000. And then I asked the surgeon, I said, okay, what do we do now? Is there something like chemotherapy to follow up with? And we were told, nope, there's nothing to do. Surgery should have taken care of it. But we did do scans for, it may have been 3 years, it could have been as much as 5, and nothing showed up. And so we went merrily on our way. And then in early 2015, in April, Michael started showing trace amounts of blood in his urine. I mean, it was nothing we could see with our eyes, but his doctors caught that. And they tried a number of different, they thought, well, maybe it's a kidney infection or something. So they tried the usual antibiotics and treatment and whatnot. And that didn't seem to knock it. And so finally an ultrasound was scheduled in May, and that showed that there was a huge mass on his kidney. And eventually we were directed to Seattle Cancer Care Alliance / Fred Hutch, where they were just wonderful. They took us in, they took care of a lot of the paperwork and a lot of the worrisome questions that I had, because I'm an organized person and kind of a type A, and I wanted to take care of Michael and take care of all the paperwork and investigate everything possible. It was suggested by a nephrologist that Michael's going to have to lose his whole other kidney. Michael didn't want to do that. We were aware that we were kind of on the cusp of some new treatments for kidney cancer, targeted therapy being one of them, which targets and goes after the part of the kidney cancer cells that helps them to grow and survive. And or a little bit later on, immune therapy came on, which kind of activates your own immune system to go after the cancer. Michael elected to do the targeted therapy first, and we got about 2 years out of that before it stopped working. And then we tried the immune therapy, and that didn't cut it either. And so finally, Michael had to lose his only remaining other kidney, and he just absolutely hated that idea. And I said to him, he said, I'd rather die than go on dialysis. And that sounded pretty extreme to me, but I believed him. And I said, let's give it a try and see how it goes. And the option is yours. So we did 3 months in a clinic of dialysis. And then we became aware of a program where we could do it at home, which would give us a lot more freedom. We could do it more often. Medicare pays for it. But if you go in a clinic, they only pay for 3 days a week. If you can do dialysis a little bit more often by doing it at home, that helps the patient, it helps the kidney, it's maybe not quite as hard on the body. So we both took a class, and I became the head needle sticker and ran the machinery. And Michael was an excellent assistant. And so we did 3 years of dialysis at home. And it gave us a little bit more wiggle room in our schedule. And it was nice because it was home. We weren't driving back and forth. And he could have friends come in and sit and visit with him and have tea while he was on the machine. And it worked out very well. At the end of 3 years, one of the dialysis nephrologists said, "You've been 3 years now without any recurrence of kidney cancer or metastases anywhere. So why don't we investigate if you might be eligible for a kidney transplant?" So that's what we did. And people always want to know, well, how long were you on the waiting list? Because we had heard waiting lists are just forever. Michael was 78 years old then. And, we thought, oh, why would they want to give a nice kidney to an old guy that maybe isn't going to be here that much longer? We did have the option of agreeing to accept a lesser kidney, which meant that maybe it came from an older person or somebody who'd had a hard life living on the streets. But it would, of course, be checked first to make sure that it was safe to transplant. That's what we opted for. That's what Michael got after 3 months waiting. It worked perfectly. It started working right away, has been working ever since. We're so happy about that. And the only drawback, if you want to call it that, is that Michael has to take anti-rejection drugs every day to prevent the kidney from being rejected, which the anti-rejection drugs lower your immune system. So he has to be super careful, stay vaccinated, wear masks, and stay away from places where there's a probability that he could catch something. So we're really happy it worked out. We consider ourselves very, very lucky.
Great. Diana, thank you for sharing that information, that personal story there. I'm going to ask for both of you to answer this one, but Dr. Crum, we're talking about two diseases here. We're talking about kidney cancer and kidney disease. When you discuss this with the patient, do you ever see this as something that happens you have to have a regular conversation around this on a regular basis, or is this more of a rare situation? Can you comment on that? And then we'll talk to Diana.
Absolutely. So Diana's story is very inspiring because it gives us room to tell patients about so many different things that they need to be aware of. So certainly it's very, very frequent for someone with kidney cancer to develop kidney disease. It's unfortunately also very frequent that people need a complete kidney to be taken out. Luckily now, a lot of patients can get away with getting just part of one kidney taken out. But if, for instance, you have a tumor that's more than 4 centimeters, if your tumor is taking the adrenal gland, or if it's going into major vessels, even if it's a small tumor, the whole kidney needs to be taken out. And when you lose a kidney, basically you lose half of your functional reserve, right, in terms of kidney function. And you might say, but people donate a kidney all the time. But those people that donate a kidney usually are very carefully selected. They are people who are in perfect shape. We usually also choose the kidney that's the least healthy. They have one kidney that's working better than the other. And we also, people get monitored. It's recommended that people that give a kidney get monitored every year to see if their kidney function is still good and if they don't develop kidney disease. While patients with kidney cancer many times have other problems going on. They might have diabetes, they might have high blood pressure to start with, they might have heart disease, and all of this puts them at risk of having kidney disease to start with. And then you remove part or a whole kidney. And that's obviously, that leaves them with certain vulnerability. And then you have also the problem with the chemotherapy that can by itself be toxic to the kidney, and so on and so forth. And so this is where a kidney doctor is very often involved in the care of patients who have kidney cancer to help them go through that journey, because not only sometimes they have to deal with kidney cancer, which obviously is very hard to deal with, but then they have also to face kidney disease, which is another chronic disease, and potentially dialysis, as happened with Diane's husband. I completely understand the distress of having to deal with dialysis. Luckily, home dialysis certainly provides a better quality of life than dialysis in center, and is growing now in the US, and even can offer better survival prospects. Because when you go to a center, you do dialysis only 3 times a week, but when you do it at home, you do it every day. So you have a better control of everything. And that certainly puts you in a better health in general. Knowing that home dialysis is not feasible always for everybody, unfortunately, because people who are very sick cannot stay at home. They need to be monitored in a center where you have nurses that can take care of them. And then you have the transplant. And the transplant, a few years ago, nobody would think about giving a kidney to someone who just finished dealing with cancer. But now for certain types of cancer, we're even giving transplant for patients who are not completely cured, because the new treatments really can allow us to have a grasp of both.
Wonderful. Thank you, Diana. So, I think back to the days I first started going up on Capitol Hill talking about kidney cancer, and people got me confused with kidney disease. So when you all were first learning about these diagnoses, tell us about how did you distinguish the two and keep track of what was going on?
Well, for me, I didn't know that I thought that kidney disease was one thing and kidney cancer was something else, and there was no relationship between them. And I just learned that a few weeks from you, Dr. Scrum, when we had spoken earlier. But Michael had no history of smoking, high blood pressure. He's never been overweight. He doesn't drink. He was healthy. At the most, he's a small man. At the most, he's only ever weighed 135 pounds. And so he had none of what I would understand to be the characteristic traits of somebody who might be vulnerable for kidney disease. We think, and there's no solid proof, the government has recently gotten very engaged in veterans who have been around certain kind of forever chemicals in their military career. And Michael he was exposed daily to the PFOAs and the other forever chemicals. His clothing was saturated with it. Every day he was a firefighter spraying the foam. And the physicians that we've spoken with feel that there's a high probability, and there are numerous studies that support that. So Michael has gotten full VA coverage now for that disability. His treatment, however, has been entirely with Fred Hutch, SCCA. I will mention, too, that thankfully he was able to get a kidney. And he does take the anti-rejection drugs. But we were also told that there is no guarantee that his cancer in some form or another could come back, because it suppresses his immune system. And sure enough, about a year after the transplant, he did get a metastases to his one remaining adrenal. So we took care of that with targeted high-powered radiation. So far, he's doing great. The kidney is working good. There's no problem with it. So I can't answer really easily about the kidney disease versus kidney cancer. Dr. Scrum is the best person to do that.
So let me just ask you about the maybe some of the finances, if you can share whatever you'd like to share on that. So you've had, multiple therapies, and then going through doing things at home and learning and training. Talk to us about what was covered, what wasn't covered, what was a surprise.
Well, as far as dialysis goes, Medicare pays for that. And they really like it when you will do it at home, because that lowers Medicare's costs. They don't have to pay a staff in a clinic to be doing it. So the equipment, the chair, the machine, the supplies that you need, the saline, the cleaning solution to clean the blood, the rubber tubes and hoses and all the rest, even replumbing our house for part of it. And like I say, all the supplies, that was entirely paid for. We had nothing out of pocket. As far as the treatment goes, we were probably fortunate that we have a good insurance that paid for most all of everything. There was one point in time when we first started the targeted therapy when it was going to be hugely expensive, and we did apply to the company that made the drug that's being used to get some financial assistance. And that worked for a year and a half, or I can't remember exactly, but it was over a year during the time that Michael was on the targeted therapy. When he went to the immune therapy, that was given in the hospital, and so that was covered. We didn't have to pay anything for that.
Great. So, Dr. Crum, I'm going to bring it back over to you. You said earlier something to the effect of, when you have you can test to see which is the better of the two kidneys. Can you just elaborate on that a little bit for the lay person? It sounds like there's usually, generally speaking, one that's stronger than the other, and you can figure that out.
So in general, we think that every kidney does 50% of the whole work. But sometimes, and as it is the case for everything that comes in double in a person, one organ can be a tiny bit stronger than the other, meaning one kidney could do 55% of the work and the other could do 45% of the work. And there are studies that can be done by in transplant centers when they're evaluating donors to look for the one that does 45% versus 55, and then they take away the one that does 45% to protect the donor. It's still a kidney that functions very well, otherwise they wouldn't be giving it away. But it's a way to also protect the donor who's already doing something very altruistic there.
Got it. Can you talk a little bit about high blood pressure, and that's how people at home make sure they're staying on top of their blood pressure levels?
Yes. So high blood pressure can be the first sign of kidney disease, and kidney disease will give you high blood pressure. And also high blood pressure, if not treated, will make kidney disease progress and will have the kidney function decline. So one of the main jobs of a kidney doctor is to make sure that the patient does not have high blood pressure, and if he has it, to make sure that it's under control. And this is where the blood pressure in clinic alone is not enough to make the diagnosis and to follow the patient. And the patient really needs to be on top of things and monitor his blood pressure at home, comes regularly to visit, and get it under control. And so one of the, a task that needs to be done to someone who's at risk for kidney disease is to really make sure that they don't have high blood pressure. And also for someone who has high blood pressure to make sure they don't have kidney disease.
Is it true to eat oatmeal helps?
Oatmeal, in general, also oatmeal is grains. In general, a diet that's plant-based, meaning is rich in fruits and vegetables and grains, and poor in meat and saturated fat and processed food, is good for everything. It's good for the kidney, it's good for the heart, it's good to lower the blood pressure, it's good to protect you from cancer. So basically, we should go back to eating like our ancestors used to eat.
Fair enough. Fair enough. Diana, do you want to just talk a little bit about the home training slash what it took to get to where you were feeling comfortable that you could have your husband at home administering this 4 times a week?
Um, we took a training class, and it lasted for 1 month. And every day we went into the clinic, and they first taught us about the machine. And within about 3 days, it was our responsibility to get the machine all primed and set up. And meanwhile, for those first 3 days, the dialysis nurse was showing us how to place the needles. Fortunately, I have a background in dental hygiene where I gave injections and I even set up some IVs, so I had no problem about sticking a needle. And when you do dialysis, you can have a surgery ahead of time that joins a vein and an artery, so to speak, so that there's one vehicle for input and one vehicle for output. And they get quite swollen. They get big. They look like Michael had big biceps. So I had a nice target to aim for. You do have to be really, really careful. And of course, sterile technique is very important. But I had no problem sticking the needles. And so it was easy to transfer after 1 month when we were ready to start doing it at home. We did have somebody come and visit us the first day to make sure everything went well. And we had 24-hour on-call help available. So if the machine malfunctioned or did something weird, I could call. We had about 3 minutes, during which time we had to resolve whatever the problem was, because if we had to turn the machine off, if it stopped, it would be stopped in the lines and it would start to clot. So if we turned it back on, we couldn't be putting clotted blood back into Michael. So that was probably the most challenging thing for me, was if there was ever a malfunction, being under a little bit of pressure to get it resolved. But we did it, and it worked fine. Did I answer that?
Maybe just to push a little bit on the blood pressure, and Dr. Karam, help us here. What numbers I know it varies by person, but are there ranges that people can go to and find and do these home readings?
So yes, certainly. So I usually spend a good amount of time in clinic showing people how to take properly their blood pressure. For instance, you need to empty your bladder before you take your blood pressure. You need to be in a quiet environment. Rest for 5 to 10 minutes. You need to use a validated machine, and not all machines are validated. You need to use a cuff that's not too tight or not too loose. It needs to be at the level of the heart. You need to take at least 2 measurements at any given time, and so on and so forth. And you need to take this over a long period of time. So I actually ask them to take it over a week. And we try together to aim for a blood pressure of less than 130/80 by adjusting their medications, having frequent follow-ups. And now, of course, some people need to have different targets depending on what they have in terms of diseases.
Diana, what's been your experience? How often do you all take blood pressure at home?
Michael takes his blood pressure every day, and he has at least twice a day, actually, in the morning and in the evening. He has he's very techy. He has some kind of thing on his iPhone where it records it. So when we go to the doctor, he can just pull out his iPhone and show it to them. back when I was a dental hygienist, I took blood pressures on all the patients. And before all of this came about, I think we had a blood pressure cuff at home, and we probably took it every so often, but he never had high blood pressure. As a matter of fact, it was always low. And it wasn't until just before his diagnosis in 2015 that his blood pressure started shooting up. So that was the tip off.
Got it. Got it. Yeah. Are there, Dr. Crum, any home devices or watches, Apple, not plugging anybody in particular, but are there any home devices that, other than a cuff, people should have?
So there are certainly a lot of devices that are now being developed on the market. But so far, the American Heart Association really only recommends a handful of devices, which are usually through a cuff. And experts from the American Heart Association got together and put together a list of devices that were validated. Because believe it or not, the FDA does not require necessarily for a device to be tested through trials as being accurate to be put on the market. And only around 15% of the devices on the market are actually validated, meaning they can be tested in trials as being accurate. And this is different from calibration, where you take your machine to the doctor and you calibrate it. And so there is a website called validatedp.org, which lists all those devices. And I also provide usually my patient with this website.
Thanks very much for that information. We'll try to get that shared. Just another, I've got a couple of questions that I've gotten sent to me. One is around diet and lifestyle. And the question, Diana, was there any change in your diet or exercise or lifestyle during these different processes, different therapies time?
While Michael was on targeted therapy and a certain amount of carryover on when he was in an immune therapy, he had been kind of weakened a lot. And so his activity level was very, very low. He had nausea and diarrhea, which are side effects that we dealt with, necessary evils, you might say. And then when he was on dialysis, yes, his water intake was very, very restricted. And so he had to watch that. And there were a lot of different fruits and vegetables, unfortunately, that he could not have because they would have high potassium or high magnesium or one thing or another. I know that dairy was very restricted because the calcium levels were affected also. So we had to balance, and there was a lot of literature to help us. One of the things that he could eat was red and green peppers. So we had a lot of meals that involved grilled red and green peppers. But so yes, we did have to watch our diet, but it was not a terrible to deal with.
So this is where I might weigh in very quickly. There are two types of diets that probably would be worth mentioning when someone has kidney disease. So there is the type of diet which would preserve your kidneys and preserve your heart also health, because they're actually the same. And this is where you're generally at an early stage. So again, it's recommended then to eat fruits, vegetables, grains, non-saturated fat. But when you are on dialysis, like Diane's husband, and you have no kidney, so basically both his kidneys were taken out, this is where dialysis does imperfectly with the work of the kidney. And this is where, we do almost the opposite. We tell the patients not to eat a lot of fruits and vegetables, which are rich in potassium, not because they're bad for the health in general, but because the potassium will accumulate if otherwise, because he doesn't have any kidneys there. So this is a very important concept for patients to understand, because sometimes they say, well, someone's telling me potassium is good for the kidney, someone is telling me the other way around.
Okay. I'm going to shift gears. There's another question here for Dr. Crum regarding what is the impact of kidney disease on kidney cancer patients in clinical trial enrollment?
So this is actually a very important question. Unfortunately, when drugs are usually developed for cancer, and not just kidney cancer, patients with poor kidney function and with advanced kidney disease get completely excluded from those trials. And while in real life, obviously, it's very frequent to have kidney disease and to need cancer treatment. And this is where, unfortunately, again, in real life, a lot of those patients get excluded from getting a treatment that could save their life, just because we don't know if it's safe to use it in them, or we don't know how to adequately dose the medication, or we're afraid of giving a medication that might make their kidney disease worse. And this is where this needs to change at all levels.
Got it. Got it. Thank you. Thank you for that information. So, did you all, Diana, did you all hear about clinical trials or have any opportunities to be involved? I don't think.
Yes, our oncologist at Seattle Cancer Care Alliance was leading up a trial, and he wanted Michael to go on that. And so we did some preliminary tests, but unfortunately, Michael failed the preliminary tests because he was having ongoing complications from the kidney cancer. So we didn't get to do the trial, but we got to start taking one of the medications that was being tested on the trial.
Dr. Crom, could you just pick up on that? And do you have an opportunity to talk about clinical trials to your patients, and how do you incorporate that into your conversations?
Yes, so yeah, I certainly talk about clinical trials with my patients. Clinical trials are essential to advance medicine. And an informed patient is a patient that's important to have, and I always encourage them when it's safe for them to enroll in clinical trials.
Yeah, and do you point them any direction in particular, or because we at the NKF and KidneyCan, of course, know about clinicaltrials.gov, other organizations, other resources out there?
Well, usually there are several trials at my own center that I direct them to.
Sure.
And or I direct them to people that are involved in certain clinical trials. And another useful source is most academic centers list on their website what clinical trials they are running and which patient could be eligible for those clinical trials. And I encourage patients to always look for that.
And I just want to ask you one more time, Dr. Crum, nephrology was a new world when I was diagnosed, and everybody, who's not familiar with the kidney world, what should they do if they have an opportunity to talk to their care team and haven't heard about a nephrologist yet? Should they ask for another opinion, or how do you get more involvement?
So, most cancer centers now have a nephrologist on board with them. People have realized that a nephrologist is a major member of the care team, not only to deal with the consequences and put someone on dialysis, but mostly to prevent someone from being on dialysis, to advise the team about giving medications to patients, to help them dose the medications, to sometimes come there and say, listen, even if this patient has not such a great kidney function, I think that he's healthy enough to get the drug. Let's give it to him. And also, again, as I said, the nephrologist, in my opinion, is a big part of the care team to support emotionally those patients and to give the care that, the oncologist does not have the time to give, because, the oncologist is mainly focused on giving the treatment, while the nephrologist could take care of everything around that treatment and support both the patient and their family.
Great. Thank you, Doctor. I'm going to remind everybody, if you have any questions on this subject, please post them in the comments section, and we'll do our best to answer as many as we can. If we've run out of time and you have questions, check on the National Kidney Foundation or KidneyCan's Facebook pages after the program. And I think with that, I guess I'm going to ask both of you this wrap-up question here together. What are the one or two takeaways you want the audience to go away with? And I'll start with you, Diana. What do you want to leave the audience with today?
That there is an awful lot of hope. There are a lot of new medications and treatments being developed right now. I am aware of people who have gotten a very severe kidney cancer diagnosis who are still with us 16 and 17 years later. There are a lot of different treatments. So there is definitely hope. Look at our story.
Thank you, Diana. Dr. Crum, I'm going to give you the last statement.
Absolutely. So indeed, Diana's story is enlightening. You can get cancer, you can get cured from it, you can get another cancer, get cured again from it, and you can reach dialysis and also find hope at the end of the tunnel. Through this journey, it's important to involve several specialties, the oncologist, the nephrologist, the surgeon, and know that you're not alone. A lot of progress has been made. A lot of progress needs to be made as well, especially when it comes to giving medications to patients with kidney disease and kidney cancer and having them part of clinical trials.
Great. Thank you, Doctor. Well, unfortunately, folks, we've run out of time today. In case we didn't get around to answering any questions, as I mentioned, check on our Facebook pages over the next couple of weeks. We can have some answers out there for you. We'd really like to thank our sponsors for their generous support in making this program possible. And I'd especially like to thank Diana and Dr. Sabine Karam for joining us today and helping us to make sense of what I know can be a very difficult subject, trying to connect the dots between kidney disease and kidney cancer. So thank you both for being here today. Well, on behalf of the National Kidney Foundation and Kidney Can, I'd like to wish all of you some good health. Have a great week.